So here we have just introduced our endoscope, and thereby we are clearing the soft tissues over the lamina with the help of the RF probe. So all the soft tissues are being cleared, and the lamina margin of L4 is being freed of all the soft tissue. This is the interlaminar space which is being cleared of the overlying soft tissues, and we're preparing our borders, the lamina border, for burying it with the shaver or burr. So we are using the we are using the cutting burr over here and are doing the laminotomy. That is the inferior border of the upper L4 lamina is being burred out. So often we see these soft tissues coming in between, so we have to use an RF probe in between to clear these soft tissues, like we are doing right now. Some blood vessels and all small bleeders which come in the way, they have to be coagulated with this RF. The blood pressure should be kept under control while doing this endoscopic procedure, because often blood coming in our vision creates a lot of problems. The guidelines say that systolic blood pressure should be around 100 mm of Hg, which makes the field a bit more favorable for us. Continuing with the burring over here, and also towards the midline we are burring the base of the spinous process, that is at the 12 o'clock position. Continuing with the burring of the lamina borders and the base of the spinous process. So here with the dissector, we're trying to tease off the ligamentum flavum from the base of the lamina. And for the using our Ferrisons, we can do bigger cuts as compared to the slow burring. The laminotomy becomes a bit more faster when we use these upcutters rather than the use of that burr. So intermittently we use these burrs further where we need to do the upper surface clearance of the bony overhang of the lamina. By burring the base of the spinous process, the midline spinous process, gain access to the contralateral side. So if you look clearly, we can see that the junction of the two sides of the ligamentum flavum can be visualized. That's the junction what we had been looking for so far. And just below that will be the fecal sac. So that kind of marks the sufficiency of the laminotomy being done. However, for demonstration purpose, we'll do a bit more of the laminotomy in this video. remove the carisons, we are trying to remove the ligamentum flavum over the thecal sac. Also simultaneously removing a bit more of the bone, doing undercutting of the lamina. Thereby also trying to free off the ligamentum flavum from its attachment, from its bony attachments. The dissector, we are further trying to clear off the soft tissues, trying to identify the nerve root and trying to identify the disc herniation lying below the thecal sac. It's always a combination of the RF, the dissector, the carisons, which are often used interchangeably to further define our borders, to do the clearances of the soft tissue and the bony structures, and to expose our nerve root and the disc. This is like we are working in the shoulder area of the nerve root, the junction where the nerve root leaves the dura and becomes a separate entity. That's also the area of the superior facet of the inferior vertebra. We are exposing the nerve root and clearing all the soft tissues around that particular nerve root, doing a bit more of the foraminal. Ligamentum flavum attachments to the inferior vertebra are being removed. That is the disc. See, this is the disc, a beautiful disc. While we are tracting the nerve root and the thecal sac, such a beautiful disc is recognized. And this is what is the positive agent of the pain for the patient, and this is what we have to remove. So for the same incision on the working port, we're using a nerve root retractor, which the assistant is holding from the other side and retracting the nerve root towards his side. And now we'll introduce our Indian knife. And with the Indian knife, we are doing this annulotomy and going to the disc space. And here comes our disc. So using our disc punch, we're removing this disc part. So whatever loose is there, all the loose fragments of the disc are being removed. This is a bit of annuloplasty that we do with the RF probe. So this causes a bit of fibrosis and reduces the chances of a recurrent disc herniation theoretically. Just whatever precautions that we can follow from our side by doing this annuloplasty to prevent any such disc herniations for the patient in the future. Just looking for any further loose fragments. Removing whatever we can. Just trying to do the best for the patient and leaving the least and just leaving whatever is intact to prevent any recurrences and such episodes of pain for the patient. Removing parts of the inferior lamina doing foraminal. Free the nerve root as far as we can. This is burying undersurface of the contralateral lamina, that is the right-sided L4 lamina's undersurface is being burred out. Using dissector, we are trying to peel off the ligamentum flavum from its bony attachments on the contralateral side, and further using the keratins to detach the ligamentum flavum from the undersurface of the lamina. By feeling the contralateral nerve root and also the middle wall of the pedicle and removing the ligamentum flavum from that side. Then using the Indian knife, we're trying to do the anelotomy on the contralateral side over the shoulder area of the contralateral nerve root. And after doing that, we obviously using the discourse to do the discectomy that side. Then further clearing the soft tissues over the nerve root, doing foraminal for that contralateral nerve root. The curved carisons also work out very well when we do foraminal for the contralateral nerve root. I suggest we should have these instruments, the curved rongers in our armamentarium when we do these ULBD surgeries. The dissector, we are checking for any ongoing compression of the nerve and removing of whatever is necessary to clear off the nerve. So here with the nerve root fracture, we are trying to retract the nerve root and look for any disc fragment which might be there. But we're just trying to remove whatever this fragment needs to come out. Just following all the precautions from our sides to leave anything behind, prevent recurrences. And thereby also doing the annuloplasty and shrinking down whatever is there. that's your endoscopic procedure. You can see that the nerve roots are free, the apical sac is decompressed well.